in Madam's voice. Today we have an echocardiography quiz. I think, when I made this quiz, I understood that there are going to be fellows from all the levels and all the years. So it might be a little more challenging for some of you, but I think it's going to be a good process for all of you to give it a thought on the images. And then we will also have a short discussion after the question. So what is going to happen is we are going to have a total of 15 pictures, and there could be more than one video for every case. We will have the questions after the video is being played. So you may not understand what question is going to be asked, so see the video in general for everything. And then we will have a particular time period for every case for you to answer also. You can write your answers in the chat box, and after that we will have a short discussion on that case. So we will start with the first image. So all of you can see this video. It's a 4-chamber video. I'm going to play the video once again. So I'm sure all of you know what type of study is this. Yes, so it is agitated saline contrast echo, that's right. So now we will go into the further questions. So what was the diagnosis in this case? If you paid attention to when was the contrast entering the left heart, you could have a clue on the diagnosis. Yes, so it was after 3 beats. What is it suggestive of? If the contrast comes after 3 beats, yes, so it means that you have communication at the pulmonary arteriovenous levels. Can you name 2 methods by which we can make the contrast effect better? Elevation of the arm, yes. Mixing with a little blood, yes. And can you name 3 conditions where this study can be useful? You could name conditions other than pulmonary AV malformations where you have seen this study being used. BDG, yes. So single ventricle, I think, is a very important subset where you could consider using contrast study. Fontan fenestration, pH, abnormal systemic venous drainage. Yes, that's correct. So now we will go through the answers. So we have pulmonary AV fistula as the probable diagnosis. As you said, you could squeeze the arm or elevate the arm, add a little blood, or add a little air into the blood to make it better. And it can be used after a BDG and a Fontan operation. So BDG and a Fontan operation, it could be used when you have a child who is desaturating to understand if it's a sizable fenestration shunting right to left, or it's a missed left superior vena cava, which is still draining into the ventricle, which is causing desaturation, or after a BDG, it could be an AV malformation, etc. Intracardiac right to left shunts, and in severe PH, and left superior vena cava to coronary sinus, which is unroofed. This is a common entity which is there in atrioventricular septal defect, where if the child is desaturating, you could double check it with LSVC2 unroofed CS. I get one answer, right pulmonary. In a way, we are telling that it's a sizable pulmonary arteriovenous malformation. So I think it's understood, and now we will go to the second question. So this is how our flow will be. We'll be playing the video first, and then you will have a set of questions. And if anybody has any extra doubts, you could chat it. So you can see this is the plaques view. I'll play it once again. So whatever is abnormal is seen very clearly in both the images. If you don't get the diagnosis, it's okay. You can write your differential diagnosis. Yes. So I get one answer as supramitral ring. So you need to tell what is the diagnosis. So one possibility is a supramitral ring. Do you have any differential diagnosis? Yes, so I get lots of answers. So it's called triton sinister. Yes, so you have two possible possibilities in this child. One is a supramitral ring, second is a cotritum sinister. What if this lesion was present on the right side? So this is a cotritum, which is a typical cotritum. When it's present in the left heart, it's called sinister. And if it's present on the right heart, what is it called? Okay, so I get an answer as Chiari network. But if it's true cotritum on the right side, then there is a name for it. Yes, it's called Dexter. Cotritum Dexter. Chiari network would be one of the differential diagnoses for cotritum Dexter. So do you have any associated lesions when the cotritum is present in the left atrium? Do you have any two common associated lesions other than ASD? Any associated lesion which you could name? Okay. PVC. Okay. And when you see the ASD, which is a common association with cotritum, where is the ASD present? You can understand that inside the left atrium, because of that extra tissue, you have an upper chamber and a lower chamber. So it's commonly with distal, okay. And how do we differentiate supramitral membrane and cotritum if it's present in the left atrium? Is there a way for us to differentiate? Yes, left atrial appendage. So the left atrial appendage is below the cotritum but above the supramitral membrane. So that's how you would differentiate. So let's go through the answers. So the diagnosis was cotritum sinistrum, but I agree that supramitral membrane also could have been a possibility because I did not show you the LA appendage. The cotritum dexter is the one which is present on the right side. The common associations with cord triatrium are basically left superior vena cava and atrioventricular septal defect. And ASD, yes, commonly it enters the lobar chamber, but it can enter either of the two chambers. So now let's go to the third question. This is going to be an easy one as much as the diagnosis is concerned. However, we are going to go into a little more of echo peculiarities. So I'm sure all of you know what's the diagnosis in this child. Cardiomyopathy is one area where we commonly do not see such cases, and also that we commonly do not do a complete echo understanding for these babies, and hence this slide. So the diagnosis, I'm sure, yes. So would you say it's an obstructive cardiomyopathy? It's written hypertrophic obstructive, or you want to say it's hypertrophic cardiomyopathy? Yes, so it's hypertrophic cardiomyopathy, and now we are going to have few questions on this. You will have to tell what are the two hallmarks on M mode for this condition. Yes, it's non-obstructive. So do you have any hallmarks on M mode typical for hypertrophic cardiomyopathy? Okay, so I get answers as systolic anterior motion of the mitral leaflet, asymmetrical septal hypertrophy. Okay, I agree with one. Okay, let's go to the next question. What is the cause of subaortic obstruction in this condition? So what typically causes obstruction in the hypertrophic cardiomyopathy? Okay, so it's dynamic, but because of what? Why does the dynamic obstruction come? Okay, one is systolic anterior motion of the mitral leaflet. So why peculiarly there is systolic anterior motion of the mitral leaflet? Okay, how much ejection fraction do you expect in hypertrophic cardiomyopathy? More than normal. And why does it happen like that? Why commonly you will have your EF as 78, 80, 82% with this type of LV? And what is the characteristic? Low LVEDV. So do you want to modify this? Is it the end diastolic volumes? So we go back to our basic definition of ejection fraction. And what's the characteristic mitral inflow Doppler pattern? Because we understand hypertrophic cardiomyopathy is not basically a systolic disease, but it's a diastolic disease. Triphasic. Maybe could you elaborate on this? Triphasic, is it regarding inflow Doppler pattern? the L wave. L wave is the name for which wave? Okay, so let's look into the answers. See, the thing is that mid-diastolic wave. Okay, the thing is that cardiomyopathies, commonly we do not follow systematically every single point which we really need to do. So what is important for us is we need to put all the markers for all cardiomyopathies in front in the echo room, so that any child comes, we systematically do every single parameter. Especially with restriction, I think it gets very difficult when we want to understand what happens on inspiration, expiration, etc. So the more typical features are asymmetrical septal hypertrophy and systolic anterior motion of the mitral leaflet. So we based on the IVS posterior wall ratio, we can diagnose the lesion. So that's how it's a hallmark. Now the systolic anterior motion of the mitral leaflet typically happens because there is this significant septal hypertrophy and the mitral valve leaflets are anteriorly displaced, because of which mechanically the LVOT is a little small, and also if you see the mitral leaflets, they coapt at the body and not at the tips. And this is why you see both the things. You see the LVOT obstruction and you see the systolic anterior motion. And for that answer that ejection fraction is falsely elevated, it's the systolic volume which is lesser. If you see in systole, the LV is so squeezed. A very few ml you will find if you try to measure the volumes or dimensions in systole and not the diastole. And the last is the EA ratio is reduced. That's right. Just a marker for diastolic function. So now with this understanding, we will go to the next question. Now this is actually for diagnosis. I think it's a very easy one. I'm sure all of you will agree that this is a very easy diagnosis. Okay. Nidhi, can you see that last image once again? Okay. Can you see this, the long axis? See, the sinus is a structure which is above the aortic valve. Where do you think this is communicated? See, whatever defect you see, is this see where the communication is? See, this is the aortic valve. So I get aorta to LA, RA. Okay, correct. So you got it what I am trying to say. See, this is the aortic valve. This is a structure which is below the aortic valve. So that's how you would differentiate a VSD and any communication through the sinus. So this is what we have. So what would you call it as? You're saying it's aorta to RA. And see here, it's not the aorta. It's a structure below the aorta. So what will you define this entity as? Correct. So I get left ventricle to right atrium. It's a perimembranous VSD. Yes. So that's right. So what type of a VSD is it? And what is unusual here? So that's what you understood, that this is a perimembranous VSD. Now, whenever we have a membranous VSD, what is the chance that we will have this over time? In a way that we know VSDs can close over time, and there are ways it can close. Approximately, if there are 10 PM VSDs, how many will go into this future? And does it make any difference for the surgeon if you have this? It will never close spontaneously. Okay. I actually am not very sure, but I understand what you're trying to say. So if it's a true Garbodi, that means that, see, there is one which is there, and the second which is getting closed by the tricuspid valve aneurysm and trying to close the membranous defect. I'm not very sure if 100% it will not close over time. Because at the end of it, if it's a defect in the membranous septum, the atrioventricular defect is a part of the membranous septum. It's between high pressure to low pressure. Okay. Okay. So this is an atrioventricular shunt or an LV2RA shunt. And out of 10, every 2 or 3 membranous VSDs finally have the tricuspid valve tissue closing it like this and causing an LV2RA shunt. And I agree that it's from high pressure to a low pressure setting. So it has to flow obligatory. And for the surgeons, tricuspid regurgitation residual post-operatively. Yes, surgical patch, part of repair through the tricuspid valve. Yes. So residual tricuspid valve regurgitation possibilities are there higher compared to usual membranous VSDs. Yes. So now we will go to our 5th case. Sorry, we'll play it once again. So what is your diagnosis in this child? Non-compacted cardiomyopathy. Yes. So the ventricle falsely looks like it's hypertrophic, but so many times as you closely look into it, the myocardium, more than hypertrophy, it's actually non-compaction, which gives a feeling. So when do you think this pathology starts? The non-compaction pathology starts at what age in the baby, and what are the 3 worries you have? Yes, so it starts in utero. That is very correct. Why do you think, Akshita, it starts based on what do you think it starts in utero? And whenever you see a non-compacted ventricle, would you worry about anything? Yes, arrhythmias, ventricular arrhythmias. Actually, if you see in this baby, the baby was very bradycardic. The heart beat. So whenever you're looking into the structural understanding, also make sure that you do not forget something which is so clear in terms of tachy, brady, etc. Ventricular arrhythmias, yes. LV dysfunction, yes. So that's good. So it is basically non-compacted LV or spongiform cardiomyopathy, and it starts in fetal life because the basic Pathogenesis with non-compaction is that it does not compact. So normal LV myocardium compacts in embryonic life, and here it does not. So the issue starts right from fetal life, and you have it in isolation, or sometimes you have it along with structural heart disease, or it can also happen when a ventricle is volume loaded. So long-standing Rieger's lesions, etc., can also give a feeling that it's a spongiform cardiomyopathy. And whenever you have it, one is arrhythmia, second is systolic dysfunction, and third is clot formation in those devices. So though we do not have very clear guidelines, I think the question comes, should we give antiplatelets to them? No role for empirical antiarrhythmics, and follow-up is definitely needed. And second thing is, there is some connection between carnitine deficiency and isolated spongiform cardiomyopathy. So there is some role of carnitine in these babies. Good. So now we will go to the next case. So we have 4 videos here. You don't have to come to one particular diagnosis. You can even describe your findings and then narrow down your differentials. Abstain? Okay. Akshita, can you look into this image very clearly? See, this is the 4-chamber view. What is the characteristic feature of an abstinence? Okay, is this seen very clearly? Where is the septal leaflet? Grossly dilated right heart. That's right. And the most common, we are so used to seeing abstinence. Correct. So displacement of the STL. So can you see here the STL? See this? See, this area is the moderator band. Hugely dilated right heart. Yes. And can you see this small tissue? This is the STL. So it looks like it's quite in place. Let us see if you find it in this view. But this is more for showing the outflow tract. In this also I haven't. See this STL? See, the STL is quite in its place. See, that's the STL. So, okay, so I'm getting answers like cardiomyopathy on the right side, Wool's anomaly, and arrhythmogenic right ventricular dysplasia. Yes, so I think we are very close to that. So the diagnosis is yes, and sometimes on echo you may not be able to differentiate all these. So your likely diagnosis could be all these 3. And what complications would you expect in this condition? Yes, thrombus formation, sudden death, yes. So similar to the ventricular cardiomyopathy, the right ventricular cardiomyopathy also, sudden cardiac death, arrhythmias, RV failure, clot formation, yes, perfect. So this is basically, you can term this as right ventricular cardiomyopathy, and you may not be able to go exactly into the diagnosis, but RV cardiomyopathy. So very important, please make sure you see the attachment of the septal leaflet. Here in this baby, you saw the leaflets were so thin. So it was not only the disease of the myocardium, but it's an endomyocardial sort of an abnormality. So the leaflets are also very thin, not having enough tissue into it, and then the myocardium is also abnormal. You saw the outflow tract was so ballooned out. So for the diagnosis, you will have to do MRI, and sudden death, arrhythmias, clot formation are common complications in this. Yes. So now we have seen few rare things like LV cardiomyopathy and RV cardiomyopathy, and then we go to the next. So we'll play all the images once again. You focus on your problem. Problem in the sense that just see if you find anything grossly abnormal in this child. Do you think there's any side dilatation of chambers? And then you go into the possible causes of dilatation of the chambers. The color Doppler actually peculiarly shows the clue. Yes, correct. So the right heart is dilated, and now you will run through your thoughts where all the right heart becomes dilated. ASD, TAPVC, yes. So is there an ASD? That's why this subcostal is kept. Do you think there's an ASD? So you think it's a TAPVC? Simultan. Yes, correct. So what we will now have is, yes, correct. So the diagnosis is what? Uh, I haven't shown you all clippings, but to say PAPVC is very much right because we have seen the IVC having an additional red flow into it, and also the parasternal short axis where only the left-sided veins were entering into the left atrium. The right-sided veins were not entering, so it looks very bold on the right side. So it fits into the whole understanding where we have right heart dilatation, but there is no ASD. So remember, for a TAPVC, we need an ASD usually, and the left-sided veins were entering into LA, so we ruled out a TAPVC. So if it's a PAPVC, then what associated lesions would you want to rule out? So once you think it could be a scimitar, then what else will you make sure when you're doing an echo? Hypoplastic lung, okay. So while doing an echo, how will you pick it up? Yes, so you will try to look for the right pulmonary artery, which is usually on the smaller side. A collateral from the descending aorta, most of the times difficult to see. And hypoplastic lung we cannot make out, but if the heart is dextroposed, okay, now I get an answer saying that it's dextroversion. See, there is a difference between dextroversion and dextroposition. What is the difference? Both are types of dextrocardia. So if you go into dextrocardia, there are three types of dextrocardia. One is mirror image dextrocardia. The mirror image dextrocardia has classically situs inversus. So it's exactly the mirror image. That is mirror image dextrocardia, situs inversus. But if we have situs solitus, then it can be either dextroversion or dextroposition. Now, when we say dextroversion is something which has happened in a wrong way during the rotational axis of the heart. So, in that situation, it's a true dextrocardia, but you have situs solitus. Yes, it's across the axis of the heart. Whereas dextroposition is something to do with push and pull. So in this child, if you have a smallish right lung, it's going to be more dextroposition. Now clinically, can we differentiate? Maybe not, but echo-wise, yes, we can differentiate dextroversion and dextroposition, and maybe we will talk about it sometime later. So it's dextroposition. and the smallish right pulmonary artery or collateral, and sometimes you can have a scimitar with a PDA, coant, etc. So very important message with this case, do not skip your subcausals and always put your color Doppler into the IVC. This flow into the red flow into the IVC is not usual. If you find anything like that, be very, very careful to make sure that you rule out the anomalous pulmonary venous drainage. So now after this case, we have this one. Now this is actually a very uncommon situation, but if you have seen it at some time, you will pick up the diagnosis, or else you can just tell what your findings are. You can just describe the view. What are you seeing here? Yes, parietal and short axis, and you feel there is dilated PA? Akshata, which pulmonary artery do you think dilated? The main pulmonary artery, the MPA. Okay. Anything further after the MPA do you think is not the usual one? No proper branching. That's right. So no proper branching in the sense we think the branches are not there, or the branching way is not the usual way. The left pulmonary artery. There's something wrong with the left pulmonary artery? Stenosis. Okay. Yes. Anything other than stenosis can you see? That's very nice. You feel it's right pulmonary artery to LA. LPA from RPA. Yes. Yes, correct. So now let's look at the questions. Yes. Yes, LPA sling. So the diagnosis is actually this child had LPA sling. So what symptoms do you expect if you have an LPA sling? Spider, yes. Do you expect any associated intracardiac anomalies? Dyspnea. See, practically LPA sling does not cause most of the times pulmonary arterial hypertension or any back pressure changes or any symptoms related to pulmonary blood flow. So I feel dyspnea is going to be unlikely. Upper airway obstructive lesions, yes. Do you think any intracardiac association is common? Collaterals to right lungs? Why do you think there will be collaterals? Because the course is anomalous? Okay, VSD. So let's now see. The diagnosis is LPA sling, and the important thing here is you saw how the branching pattern happens correctly as you picked up. The branches do not come the way normally it comes. So the right pulmonary artery comes in the correct way, and the left pulmonary artery actually goes a little forward and takes a U-turn and goes back. And this is because the left pulmonary artery practically originates from the right pulmonary artery and takes a turn and goes back, producing a sling, which could cause partial obstruction of the upper airways. And the very common differential diagnosis of an LPA sling is actually crossed pulmonary arteries. So there's an entity called crossed pulmonary arteries where you have origins of both the pulmonary arteries crossing, in the sense that the right pulmonary artery originates from the left side of the main pulmonary artery, and the left pulmonary artery originates from the right side of the left pulmonary artery. So the origins are opposite to each other, but their course is after that completely normal. And LPS link is sometimes associated with a tetralogy of Fallot or a VSD. So whenever you see tetralogies and VSDs, please make sure that you see the branching pattern. Sometimes if you don't see the pulmonary arteries in its normal position, if it's not a sling and if it's not cross PAs, then it's absent pulmonary artery. So that is the third differential diagnosis for LPS sling. So though this is rare, it's important to always make sure your branching pattern is correct, especially when you have nothing else wrong inside the heart and the child still has symptoms in terms of upper airway obstruction. So now we go down to the next case. Now I want all of you to see this very, very carefully. Now in this case, we are going to have only one question and you need to tell me the diagnosis. So keep focusing. I'm going to play this a little more because it's not that common. Okay, so I get one answer, mitral atresia, hypoplastic left heart. What is against mitral atresia in this child? See, I'm very nicely showing you something here. The AV valve and the seminal valve are continuous. So what does that mean? Okay, I also want to tell you something, that this is a child who has undergone surgery. Can you see this foreign body inside? Okay, so I get a single AV valve. I understand that in this view, it's not possible for you to say whether there are two AV valves or not. But I just want you to focus on this